HF10 is a herpes simplex virus that is not genetically modified, but it lacks what's called UL56, which is a neurovirulence factor. So what that means is that when we inject this into patients who have either dermal, subcutaneous, or lymph node metastases for melanoma, patients don't get a herpetic infection. However, what the HF10 does, it actually gets into tumor cells preferentially. It then replicates in the tumor cells, leads to tumor cell lysis and exposure of tumor antigens to the immune system and activation of the immune system. Now, we've shown in a phase 1 study that this can be quite effective in patients with squamous cell carcinoma of the head and neck, as well as in melanoma. What we wanted to do in this study, we really wanted to see if we can combine this with other therapies to get a more robust response in patients with melanoma. So as part of this, in this study, we combined HF10 with ipilimumab, and ipilimumab is an anti-CTLA-4 antibody. And the primary endpoint for this phase 2 study was the best overall response rate at 24 weeks. Specifically, we're interested in both patients that had received prior therapies for their metastatic melanoma, but also patients who were treatment naive. And we included patients that had stage 3B, 3C, and stage 4 disease. So the primary endpoint for this study was met. We had 41% of patients at 24 weeks had a overall response, and that was determined by immune-related response criteria. And we also followed patients subsequent to that and found that patients beyond 24 weeks there were patients that had additional responses, up to 46% of patients having a response. Now that is for us very exciting because we know with ipilimumab by itself the response rate is between 15 to 19% in this patient population. So adding this oncolytic immunotherapy, the oncolytic virus that we inject into the tumor, is quite exciting because we seem to be able to increase the response rate. Now in terms of tolerability, this was very well tolerated. Patients really did not have any substantial additional side effects compared to what we would see with ipilimumab by itself. Specifically, there were no patients that stopped the therapy because of side effects to the HF10. So we also were interested in analyzing patients who had had prior therapies versus being treatment naive. And almost half the patients in this study had received prior therapies that they had progressed on. So in those patients, the response rate was 30%, which is for us very exciting because often when patients progress on one therapy, it's difficult to get a response in subsequent therapies. In addition, patients who were treatment naive, the response rate was actually 50%. So I think this really bodes well for future therapies in combining HF10 with ipilimumab, but also other immune checkpoint inhibitors, and take this forward in treating patients with metastatic melanoma.
And you mentioned they're injecting into the tumor, so it was intralesional, not systemic?
Yeah, so we injected the HF10 intralesionally into the tumor itself. And these were injections into patients with dermal, subcutaneous, or lymph node metastases. But I think it's important to recognize also when we assess the response, this was really the global response of the patients, not just the injected and lesions that we assessed. We have also done serial biopsies of these tumors to try to understand the mechanism of action and the immune activation that we see. And those analyses are now being performed and will be reported a bit later on.
And you mentioned the patients being treated. I looked at the age data and there seemed to be quite a large variation. Do you think there might have been some better responders if they were young, or older patients if their immune system reads out senescence stage that might affect outcomes?
So we haven't looked at that specifically. We had a broad range, age range of patients, but I think the total study was 46 patients. So it's a little bit difficult to try to discern if the age makes a difference in terms of the response. Now we'll be looking at these factors, but I think that we really need larger studies to further evaluate this and see if age makes a difference in terms of the immune activation and immune responses.
And finally, this was a combination with CTLA-4. Are there any other planned combinations to try HF10 with, or say SV10 with CTLA-4?
Yes. So we actually are looking at doing the same. They're actually doing the same study in Japan right now. They're combining HF10 with ipilimumab in patients with melanoma in Japan. Now, that is quite interesting because we know the melanoma in Japan tends to be quite different compared to the melanoma that we see in the Western world. Most of the melanomas in the Western world are due to chronic sun exposure or chronic sun exposed areas, whereas in Japan the majority of melanomas are really acral melanomas, so on the soles of the hand, soles of the feet, and also mucosal melanomas. And both of those melanomas tend to genetically be quite different compared to the chronically sun-exposed melanomas. So it'll be interesting to see the effect that this will have in the patients with acral melanomas. We're also looking at expanding this further to patients who have metastatic disease, specifically patients with lymph node and in-transit metastases that we could surgically resect and use this in a neoadjuvant setting before we do the surgical resection, specifically combining this with a PD-1 inhibitor that we give HF10 plus the PD-1 inhibitor before surgery, and then 3 months later do the surgical resection, and then continue with the PD-1 inhibitor in an adjuvant setting. So all of this is really trying to activate the immune system before we do surgery to decrease the risk of recurrence of the tumor once we've done surgery.